So good morning, everyone. My name's Mark Songhurst. I'm the Scan4Safety Programme Manager here at Leeds Teaching Hospitals. What I wanted to do was start with giving you all a bit of a understanding about Leeds Teaching Hospitals before we dive into focusing on the patient. So Leeds Teaching Hospitals is one of the largest trusts in England. We have approximately 2,000 beds for patients as inpatients. We see over 235,000 accident and emergency attendances every year, and we are responsible for the care of 5.4 million patients across the region. We are the largest provider of specialist services to the NHS, so we have over 150 specialist services based out of Leeds for both adults and paediatrics. We've been on our Scan4Safety journey since 2016, and I was very fortunate to join in May 2016. So I have had various roles in Scan4Safety, from starting out with the global location numbering to now being responsible for the programme in general and setting the strategy. So if we start, we're going to start with our fundamentals, and I'm going to build up a series of building blocks that link to the way in which we manage our patients and the way in which GS1 standards, including unique device identification, fit in a patient journey with ourselves. So where does this all start? Well, it starts with the patient, and our patients can come from a number of areas. They can come, as I've said, through accident and emergency. And if you think of accident and emergency, we often hear news reports of people going there unnecessarily. Only about 30% of patients that come through our A&E doors are actually minor patients. Most of them need to be in our care. So we've got a lot of patients that will come in and will go on to become inpatients. To help manage this, we have created something called same-day emergency care. So this is somebody who may have a long-term condition that needs to be treated with hospital treatment, but may not need a full admission. We also have our surgical admissions units and assessment units that can be referred to from GPs. So a patient may be directed straight to one of those assessment units for treatment. As with lots of large hospitals, we have cardiac catheter labs. So a patient may come directly to the cardiac catheter lab, and they, of course, may be an elective patient. We may be choosing to bring them in for care. Obviously, elective is always a bit of a misnomer in the NHS, because I don't think anybody would actively choose going in for surgery or coming into hospital if they could avoid it. So that patient information is held within two systems. It's held within our patient administration system, commonly known in the organisation as PAS, and it is held within our accident and emergency system called Symphony. So when you arrive at our hospital, you arrive at the front door, we are able to think, yes, you're likely to become an inpatient, or we are going to give you treatment whilst you are here. So we need to be able to confirm your identity. At this point, we will give you a wristband printed from either PAS or Symphony. And that wristband has the basic information that we need printed in human readable format. It has the global service relationship number for the patient. And encapsulated in that is the NHS number and the PAS number for the patient. And both are important in healthcare, because the NHS number we have for most patients if we can identify them. If we can't identify the patient because they don't have capacity to give us that information, then we are able to create a temporary PAS number and join the records up once we are able to identify the patient. So all patients heading through our front door are given a wristband with their NHS number or PAS number in for us to match. And that is for any procedure that we are going to undertake that is invasive. So if we're going to stick a needle into you greater than an injection, then we will give you a wristband. So we have our patient from the point of admission. The next challenge, of course, is knowing where our patients are. So we needed to start some work on global location numbers. And I could talk for 20 minutes on global location numbers, which probably means I need to spend more time socializing with people. What we're able to do is identify all of the places in our hospital. So that is not just our rooms. So we can identify each room. We have 5 layers of information that follows. So we're able to identify the organization, the hospital site, the block, the level that that room is on, and then the room as well. Now, I think that's fairly good going for an organization that has over 22,000 rooms. Our director of medicine at the time and deputy chief medical officer wanted to be able to go down to treatment level. So if you think about this, we then needed to add at least another 2,000 bed spaces to the organization. So what we're able to do is accurately identify those spaces, and we worked with GS1 on creating a GLN plus an extension for our bed space. So what this means for our patients in terms of patient benefit is now we can come, we can do the patient identification checks, make sure we have the correct patient, and then we are able to scan the barcode on their wristband to open up the correct record and do a second check to make sure that we have the correct record matching the 2 previous pieces of data. We are then putting information in at point of care to that patient record. So we have that absolute certainty that we have put patient details in the correct record. And that's a real benefit. And when we introduced this, we also said, well, can we then locate the patient? And we've dropped the location data into the health record. So now we can also accurately know where our patients are in terms of the bed they're assigned to. And we are going through a big process of renewing this information and making sure that the way in which our hospital staff now work is by using that barcoding technology alone. They don't use any of the computer systems behind, they're at the patient bedside. And 2 stories that relate to this. One is we had a visitor who discussed how does this feel for the patient? And the patient said this is one of the best things that's happened to them because it puts a nurse at their bedside talking to them. And the second one was when we looked at patient location, we were talking with a patient and their partner said, so it's exactly what you've ordered through Amazon kind of thing. I was like, in many ways, but what we're looking after is more important. To which the patient's partner responded, well, it depends what you've ordered from Amazon. So it's a real challenge working in healthcare. And I swiftly removed myself from that conversation and left that between the 2 of them. So we're now able to identify our patient and know where they are. This is the part where it gets complex, because this is where unique device identification meets with all of this. Unique device identification is potentially for an operation or a procedure. So we're able to take the PAS information that's in the wristband and link the system in the back. So it's not just reading the wristband information, it's linking back to the patient administration system. We're in testing with also being able to pull in our theatre management solution into our inventory solution. So this would give us the unique case that we are looking at with the surgeon and the planned operating code. If we know both of those, we will be able to pre-pick what the surgeon will require. Of course, that requires your unique device identification information. So the instance of what the product is, the GTIN, sits in our catalog, GHX Nexus. We pull that data into our inventory solution, Supply X. And at the point we pull that information in, we can then also identify those really finite things of the specific lot, serial, or batch number for that product. We go into the procedure, and at point of care, we are able to check the patient wristband to make sure we have the right wristband, scan the wristband to open the records. At that point in the inventory solution, we see the patient demographic. So we see their name, their date of birth, and other identifying features that clinical staff are used to using. And that's really important because we're not just recording a number anymore that might get misread. We're dealing with the way in which a clinician interacts with their patient. We're also then able to take product information and assign it to the patient, knowing that we have the right information. Of course, at the end of this, let's keep with the procurement side. We take that information, we've used this product, the inventory solution looks at the par levels and go, you need another one of these ordering or another 10 of these ordering. An automatic order is created and sent out through our PEPOL interface to the supplier. At the same time, the information is taken from our general ledger and our balance sheet and put into the general ledger code as a used product. So we financially account for this all by that one scan of your unique device identification. To come back to the most important part that we're dealing with, our patient. What we're able to do now is take that data and use it. We can use that data to plan, so we know that this type of patient requires this kind of information. We're also able to look and do product recalls. And our last major product recall was in February 2023, when our ophthalmic lenses had to be recalled. And we had to also at that time recall active patients who had had an implant since the previous October. That was over 500 patients. I'm very pleased to say that in that product recall, the inventory team who received the request pulled the data for usage. So we then had the products that was used, the date it was implanted, the patient would not only by number, but with their name and their date of birth. And we had all that for the 500 patients within 40 minutes. The clinician responsible for this area now would like us to also be able to pull the telephone number and email of that patient. So we're working on the next challenge because it wasn't quite as close as they would like. But with that recall, we were also able to recall all of those patients within 6 weeks and see them in clinic to make sure that there wasn't a problem. And the good news is that no problems were actually found with those patients. So 40 minutes work and 6 weeks to recall and see. That is absolutely crucial. It would have taken us nearly 6 weeks to go back through a theatre book just to identify the patient. And then we've got to create the rest of the demographics and create a list and create a spreadsheet. So we've got the benefits of managing our stock, because if we've got the unique identification, we can make sure stock doesn't go out of date. And we've got the benefits of knowing what's in a patient. You'll notice in the slide that it says PPM Plus to create. That's our electronic health record. So once we've created the link to the theatre management solution, we're wanting to have a table in our electronic health record that says this is what we've implanted in the patient. We will then be able to look at what's implanted in that patient and have a table that also then says this is when it was removed and by whom. If we've got it in the health record, we will be able to send all the data we need to the Medical Device Outcomes Registry because it's in one place for us to pull the data from. Additionally, I want to get it a step further. If we can get it into there, we can get it into the discharge information. So patients will know what we've implanted into them in their discharge letter. Patients will know what we've got planned into or what we've put into them, as will their GP, because we don't just send a letter out anymore at Leeds. We email the GP with the discharge information. And if you're within Yorkshire and Humber, you can see a redacted form of the hospital record as a live system link. So actually you would be able to go in and see our records to know what was in. So in the event of that product recall, if that hits the news, patients will be able to know what was in them and just query whether it applies to them. Because quite often, if we can tell you which manufacturer it came from, they'll be able to look and go, well, it's not that manufacturer, I'm fine. We can make patients feel safer by providing them with specific knowledge. There we go. I seem to have lost control for a second there. So that's our product in our UDI. Of course, there are other things that we need to identify. And one of the things that we are working on is working with our blood tracking partners to be able to track blood across the organisation. So what we're able to do is take information from our wristband and open up a record in our blood track system. At the point of care, we're able to extract the blood that is going to need cross-matching, label it at the bedside so we know that we have the right label on the right vial of blood. This prevents wrong blood in tube being sent to the laboratories. We're in the process of commissioning our new LIMS solutions and our upgraded LIMS solutions so that we will be able to commission the fridges that you can see in front of you on the slide. From that blood, once cross-matched in the laboratory, the ward will receive a notification, and if there are no antibodies required, then we will be able to direct them to the nearest fridge with the right blood inside it. They take a slip from the ward and scan the slip. That will then release the correct unit of blood for that patient, or units if it's more than one. The system then labels the blood in addition to the labeling that's already on there so that it is uniquely prepared for that patient. And at the point that we administer the blood to the patient, we're able to use the system as an additional check. So you would have two members of nursing staff and the system telling you that you have the right blood for the right patient, all by checking, using barcode technology and using unique identification. But our duty of care doesn't end with patient treatment. Unfortunately, for some of our patients, we end up having to care for them after their death. And this is just as important as caring for our patients in life. So what happens with our patients is they will come down to the mortuary and they will have a body card with them that is prepared on the ward. We check the details of the body card against the patient wristband, and scanning the patient wristband, if it is correct, we're able to generate a barcode that goes on the back of the body card. That then gives us a barcode for the body card and for the patient. The pathology reports are all undertaken, and once they're available, we can check them against the patient and the wristband and produce a second barcode for the pathology report. When it's time for the patient to leave us, we're able to use the verification system from the generator to scan the patient and the reports to make sure that the correct documentation leaves with the correct patient. So our duty of care is maintained all of the way through. I've overshot, there we go. So that is the really important part of this. We're able to plan, we're able to know, and we're able to see our patient journey from them entering the hospital to them leaving by using barcodes and unique device identification.